We're live. Howdy. Aaron Boster here, and thanks for learning about MS with me. It is 11:40 p.m., and I can't sleep. And I thought I would come down here and hopefully chat with some of you guys if you happen to be up and about. I'll wait a few moments in hopes that some folks might join us. And in the meantime, I'll entertain myself by having a swig of water. I see 16 folks are jumping on. That's really awesome. As you come on, tell me where you're calling in from. I love to see this growing global online village kind of amass. So Sarah's here. Hey, Sarah, how are you? James is here. Hey, Christina. So share with me where you're coming in from. Meg is on. Becky's here. Jane is here. I love it. Hello, Mary. Hey, Christina. Hey, Liam. So throw a location in the chat. So I can go back later and kind of see where everyone's from. It's really fun. I'll give a few moments for folks to jump online. This is very impromptu, guys. I'm sorry. I am doing a better job, I think, of scheduling a monthly live stream. And I think actually this month's is probably coming up like next week or something. But this is just an impromptu hello, howdy, hi, because I'm full of energy right now and can't sleep. So I thought I'd see what everyone's up to. I've got my Barry Homestead, howdy, howdy. I'm Trippin is on from Austin, Texas, howdy. Sandy Nelson is on. This is fantastic. There's 61 of you that have jumped online. As you come online, share with me where you're calling in from. Just leave a message in the chat. I love to look at that. Tonight I want to do an Ask Me Anything live stream. And so the way this works is just throw a question in the chat and I'll read it and try to answer it online. I probably won't get to everyone's question, and I don't want you to fret because I'll go back later after the live stream and pull those questions out. And I typically integrate them into follow-up videos that I do, so no worries. All right, so if you guys feel like you're ready to do a Q&A, show me that you're ready by filling the chat with flames. Go ahead and get the whole chat full of flames. We can get that whole bad boy full of flames. I know that you're ready for me to start the questions. So Michelle is helping out. Luthden is helping out. Jane is in the house. Got a water problem there. Okay, get the whole thing filled up with flames. Just flames. Everything you got, flames. Do it up, do it up. All right, we're almost there. This is awesome. You guys are fantastic. All right, we did it. That's great. Thank you very much. I've got to approve some of these. I don't know why they're flagging them, but this is super fun. Thank you. So we are now ready for some questions. Go ahead and throw a question in the chat, and I'm going to try to answer as many as I can. We'll start off with Cassie Sky, who writes, newly in the Indianapolis area, moved from Montana. Just finally got all of my records to your clinic. Oh, that's awesome. And booked to transfer. Well, that is really fantastic. Well, I can't wait for that. Thank you for working with us to get you scheduled. And that's really cool. Yay. That was a fun one to read. Kathy Keats is up late at night. I've got, let's see, let's look for some other questions. Kyle Roberts is here. What's up, Kyle? He writes, can MS cause leg cramps like the MS hug? Yes, absolutely can. And in fact, both problems are from the same kind of issue, if you will. It's both part of spasticity. When you have the MS hug, you're actually having a spasm of the muscles between your ribs. So if these are ribs, not fingers, and there's muscles there, they'll clamp down, and it feels like you're being squished. When you have a cramp of your leg, it's the muscle of typically your calf or your quadricep that's cramping. So yes, and that can be treated with medicines to treat spasticity. All right, let's see what other questions we have here. So let's see. Sarah Rodriguez Robertson writes, in your opinion, would you recommend an infusion or pill? What are the pros and cons of either? So Sarah, the medicines are all different. So there are several infusions and there are several pills, like a bunch. And so I can't really divide them that way. I think really we need to have a conversation about your goals and how bad your MS is, and game out the risks of that, and try to guide you through a conversation of finding the right drug. But I can't say like infusions or pills based on the fact that it's an infusion or based on the fact that it's a pill. That's just a route of administration. So probably need some more information before I can really weigh in on that. Jane writes, I'm on Mazin. Just had huge joint pain. Not sure about that. I would definitely talk to your doctor. Christy Simmons writes in, tired all day, but can't sleep at night. Always wake up at 3 a.m. How can I get more sleep? I feel like I'm always tired from only sleeping 4 to 5 hours max every day. So again, and I'll just state this, that I'm not giving out medical advice. I'm sharing medical education. So if you're asking a question, please try to make it general so that it's just a general question everyone's learning. I can't answer specifics for people because I can't see you or examine you or all those kind of things. And you definitely want to make sure that you're asking your doctor about what's right for you. Okay, so there I said like the disclaimer, and I can't answer specifically for you, but I will tell you, Christy, that that's very common. And there's a lot of things that could be at play. So the way that we get into this is we start to figure out some logistics. What time do you enter the bed? What time do you fall asleep? How many times do you wake up? When you wake up at 3, okay, you stated that. And then when are you napping and from what time to what time? And then we go back and we look through, when is the last time that you're drinking fluids? And what are you doing when you get into the bed? And what is the setup of your bedroom? And there's a very large conversation to be had to pick apart the dysfunctional sleep hygiene, right? And we can oftentimes change some things around. So for example, sometimes people don't get a lot of sleep at night and they're exhausted. So then they sleep during the day. They take a nap, except it's like a real like 2 or 3 hour nap sometimes. It's not really napping, that's sleeping. And so if you cut the naps out or minimize them down to like a half an hour, you're still going to be really pretty tired. And if you always wake up at the same time in the morning, one of the things that happens is you start to be more tired in the evenings because you didn't nap. And so you start to consolidate your sleep. That's one small example of many things that we do to really try to game out how to help people sleep. And oftentimes through a series of conversations and some behavioral changes, we can help someone get to sleep at night and get some good quality sleep. For those of you that are new to the channel, I play this game called the MS Water Challenge. So when I'm on camera, or particularly during a live stream, when I drink, then I want you to drink. Now, right now, I'm not going to play that game because it's 11:48 at night, and I'm an MS doctor who recommends people stop drinking fluids after dinner. So this is not me showing off good behavior. So I'm not going to play that game this evening, but we will the next time. So let's see. Mandy DeHong, or I probably said your name wrong. I'm sorry. Mandy asks, "Hi, Dr. B. With MS, can you be dizzy almost all day?" Yes. So MS affects the supercomputer that runs, the whole body, the brain, right? And that includes your balance and equilibrium. And so if those parts of your brain are impacted by MS, if they're damaged, then it can cause imbalance, or it can cause vertigo, which is a hallucination of spinning. It can cause disequilibrium. So yes, that can occur. And there's treatment for it. Now, the treatment typically is not a pill. I wish there was a pill, but it's typically vestibular physical therapy and working with a vestibular physical therapist. And I have videos on my channel where I talk about balance and I discuss some of those things. So definitely check that out. So Liam is here. Hey, Liam. Have you ever known someone to be diagnosed with asthma or blood sugar problems after Lemtrada? So I've given a lot of Lemtrada over the years. I have never heard of someone developing blood sugar problems. And I've never, so no. Now, you can develop a pneumonitis with Lemtrada. And so that's an inflammation of the lungs, but it's typically right at the time of infusion. It's not something that happens a long time later. And that's not really an asthma. So I am not familiar with either of those. Now, I'm not saying it couldn't happen. I just certainly haven't seen it. So C. Collins writes, calling it a hug is a bit of an understatement. Yes. Sometimes we joke that it's the only hug you don't want. It should be called like the MS squeeze you feel like you're going to die, or some other name. You're right. MS hug makes it sound lovely, and it's not. So let's see here. So we have some silly folks that are writing things. So I have these magic buttons where I can make people disappear. And if you want to write shenanigans, then I'll just delete you. It doesn't really hurt us. Remove. Haha. All right, there. So where are we? Sorry, guys. Hey is on and writes, what are your thoughts on using invermethicin for COVID-19? So I think that the data suggests it doesn't work. And I would not recommend that. Donna writes, thank you for this chat. No worries. I don't sleep well at all. I appreciate the information and all that you do for us with MS. Well, thank you. So let's split that in half, and I want to unpack it a little bit. So even though I'm up right now because I'm having trouble sleeping, there's a lot of videos on my channel about improving sleep hygiene. So if you look under the playlist, I think fatigue is probably where I would look. I have a playlist on fatigue, and I have a couple videos on sleep hygiene. I've even done entire live streams on sleep hygiene. And there's a lot of things that can be done to improve your sleep. Now, sleep is so important. I could talk about it for a year and a half, because if your sleep is messed up, it's going to have a negative impact on your entire disease process. There's a lot of things that can be wrong with sleep, but it starts with really trying to make the sleep hygiene as best as we could. So the behaviors that allow us to get good sleep. And so if you want to check that out, instead of listening to me when I can't fall asleep, you could watch those videos and learn to sleep better. Now, the other thing, Donna, it's very nice of you that you say, you say thank you for all the stuff I do. And that's really awesome, and you're welcome. And it's my belief that a big portion of helping people live their best lives despite having MS is to educate, to empower, to energize. And that's what this channel is about. And I really find it to be a great way to convey information. So thank you for the kind words. It's something that I've grown to really find to be a very powerful, helpful tool. So it's nice to know that people like it. Thank you. Simone types, the MSBS is taking my life away. I'm willing to relocate in search of a medical support team at center that doesn't sweep the symptoms under the rug. Suggestions, please. So Simone, I don't know where you live, which makes making a recommendation challenging. One thing you can do is you can look at My MS Teams. So that's an awesome group of human beings, people impacted by MS that are all online, and that's a resource. And you could ask My MS Teams, and they're probably going to know wherever your area is and people there. So that's one idea. Another idea is to look at the National MS Society or the MS Association of America or MS Foundation. There's some wonderful organizations out there. MS Views and News is one that I like a lot. And you could reach out to them and ask them who are the MS specialists in your area. And it's a good idea to do some research. But I definitely agree with you that if you don't have a good therapeutic alliance, then you should go to someone where you could, because it's your brain and it's your body, and you deserve to have someone listen to you. Jane writes, can MS cause a sudden feeling of fear? So I'm not familiar with that. Now, people with MS have a higher risk of having anxiety, and anxiety or a panic attack can absolutely have a sudden onset of fear. So in that regard, yes. But I was thinking, I'm not familiar with like a brain lesion that causes sudden onset of fear. Typically, you don't have like amygdala lesions in MS like that. So Greg writes, sorry, I didn't have a question talking about bowel issues and overactive bladder. So bowel and bladder issues are super common in MS, very, very common. The most common bowel issue is constipation. But I have plenty of people that no, constipation is by far the most common. I mean, there are people that have difficulty with bowel control, and this can happen, particularly if there's thoracic spinal cord lesions, but constipation is the most common. Now, the most common bladder problem I see is overactive bladder, like you're describing. Overactive bladder is a phenomenon where I got to go right now. If I don't go right now, I'm going to go anyways. And I got to go a lot. I'm constantly getting up to go to the bathroom. And I have nocturia. I'm waking up to go to the bathroom multiple times at night. And typically, that's a situation where the bladder, which is like a bag, right, cramps down. So it's like the size of a little racquetball. So you drink half a Coke and you're full. You got to run. And then there's another type of bladder problem where the bladder is fine, except the bladder neck is really, really tight. You can't get urine out. And that has a different set of problems. That's the causes of urinary retention. Nonetheless, what you're talking about is super common. And fortunately, there's treatments. There's a lot of treatment for overactive bladder. And depending on the kind of bowel problem that you have, there's plenty of opportunities to work on bowels. I used to joke when I worked in hospitals that interns have a degree in I can make you poop, because it's very common that people in the hospital become constipated. And so every intern in the hospital really learns how to do whatever is necessary to help a guy move his bowels. So let's see, what else do we have cooking? I lost my place. Sorry, guys. I'm trying to scroll back to see where I was. Okay, I can't. There we go. Barbara Chris writes, I have a very odd question. Could there be any possible connection between Ehlers-Danlos and MS? I do not think so. Ruben writes, is it okay to have a baby? Yes. So Ruben, I have videos on this channel, one in particular, MS and pregnancy. I would definitely check that out. MS does not impair fertility. It does not impair or interfere with pregnancy. In fact, a woman who is delivering a baby who has MS is not high risk based on the MS. Although I don't correct OB-GYNs when they make them high risk, because I like the extra attention that they get. And the pregnancy doesn't worsen MS. On the contrary, during pregnancy, typically MS gets really quiet. So there are some things you have to think about the medicines that a woman is taking and some other important factors. And so I always want my families that I work with to reach out to me so that we can sit down and talk about pregnancy and plan out a pregnancy. Because if you're taking some of these medicines and by accident become pregnant, there could be some risks involved. Some of the medicines can cause birth defects and like other bad things. And so being planful is really the answer. Carla writes, woohoo for science and data. Absolutely, Carla. I am definitely a science data nerd. And, medicine is an area where we try as very best we can to use science and data. Sometimes we don't have science and data, or at least we don't have science. And so then we have to use best practice or anecdotal experience. And it still is an art in many respects. Christopher writes, have you seen any cases where someone had issues where their eyes won't stop watering during an attack or psychosis? I have seen psychosis. I have not seen eyes watering, although the tear ducts are controlled by the autonomic nervous system. And you could do a very weird connection to try to make that be the case. I have not seen that. I have seen psychosis. A woman who had known MS became psychotic and was admitted to a psych unit. This is when I was in residency, and we got an MRI, and she had a giant enhancing lesion in her frontal lobe. We gave her steroids for the psychosis, and she got better. C. Collins writes, I work really hard to protect my sleep. I limit water intake a few hours before bed. Smart. Putting on a familiar book or tape on low volume helps me. That's a really good idea. I'm on a second shift schedule. Bedtime, 1 a.m. with a sleep mask. That's fantastic. Those are a lot of really best practice behaviors. Liam writes, it's almost 5 a.m. here. I have to get up for work shortly. Wow. Thanks for jumping on with me. And I hope that you have an awesome day. Jay writes, Dr. Boster, I feel good when I sleep 6 hours. When I sleep anymore, I wake up in pain. That's interesting. And I've heard some people say that they feel like they oversleep. Generally speaking, we want people to have 8 hours, but that's really interesting. And maybe you've laid long enough that you're starting to get spasms and your muscles are getting tight and it's waking up and really hurting. So Richard writes, any thoughts on PPMS and dementia? I have MRIs Wednesday with neuroquants. Just wondering if there's any connection. So the word dementia, so the word mentia, mentia, means thinking. Mentia means thinking. And means you don't do it very well. So dementia means that you don't think very well. There's different kinds of dementia. So I'm not sure if you're talking about Alzheimer's dementia, which is the most common form of dementia, There are some cognitive problems that can occur in some patients with MS. So the NeuroQuant that you're referencing is a really cool software that I've been using for years when I get an MRI, and it shows us the size of the brain compared to people your gender and age. And then you get a sense of how small the total brain is and then how small the parts are. And I always pay attention to the whole brain and the thalamus. Those are the two parts that I really look at. Thalamic volume in particular, a big thalamus typically is associated with a good outcome, and a small thalamus can oftentimes be associated with a bad outcome. And so that's something that I definitely like to look at, and I'm glad that you're getting that. Now, having a smaller brain volume increases the risk of difficulty with thinking and memory, but it's not a foregone conclusion, and it doesn't mean that you're going to have dementia. So I need to know a little more to answer the question, but I hope at least that gets us started. Trucker Dancy writes, is disc bulging a common MS symptom? I have disc bulges after 6 months after diagnosis. So not in maybe the way that you're thinking. So no, MS has no bearing on your discs at all, none. The average age of onset of MS is around 30. And if you've been using your back most of your life, you can imagine that somewhere between 30 and 40, you're going to start to have disc bulges potentially. So I think it's true and not related exactly, but MS does not cause that. There's no known association. Christine Poole writes, shut the TV and computer off for at least 30 minutes, dim light. Very good technique. Jane Buck writes, are headaches part of MS? I get them almost daily. So actually, Jane, people impacted by MS are much more likely to experience migraine headaches. And any MS doctor knows how to deal with migraines because our patients get them. And so at my center, at the Boster Center, we do Botox for migraine. We have infusions of this cool medicine called Vyepti for migraine. We also prescribe a lot of lotions and potions, pills, and even monoclonal antibody shots, Amivig, that we give people to manage migraines. There's a lot that you can do to manage migraine. There's also a lot of behavioral things that you can do. So I have a couple of videos on this channel about headaches, so check them out. Madame Curieux writes, hi from Florida, howdy, just woke up. Joy Torlak writes, well, I was gonna go to sleep, but I saw that you're on. Oh, well, thanks, Joy, and I'm sorry that I'm messing up your sleep. You know, it is 12:03 and there's 138 people on, which is really neat. I'm not tired just yet, so let's keep on answering questions. All right. Randaram writes, what does it mean if a relapse doesn't relapse anymore? I'm not sure what you mean by that. Sorry. Simone writes, thank you for the education and caring, a foundation to live my best life. Adriana writes, why is it that sometimes my will twitch back and forth really fast, especially when I get hot? So I'm not sure what you mean by maybe that's a typo. So when you have spasticity, which is very common in MS, it manifests 3 ways. And one of them is a spasm, and a spasm is a bouncing of a limb. So you can typically, like someone's foot may bounce like this. And so I don't know if that's what you're talking about, but that's called a spasm. Crystal writes, what can I do about the crawling sensation in my brain? It's making me feel crazy. So that sounds super unpleasant. I'm not sure if you mean in your brain or on the surface of your skin. There is a symptom that I see not infrequently, which is called formication. So a formite is Latin, I think, for ant, and formication is the sensation of ants crawling on you. And so if you are having that, neuropathic pain medicines work for that. Now, a sensation in your head, I'm not really sure about. And it sounds really unpleasant. Now, we've been going now for like 24 minutes. This is awesome. And I want to make sure that everyone's still enjoying this. So if you guys like this Q&A, this impromptu thing that we're doing, hey, Chris, please fill up the chat with flames again. Let me know that you're right here with me and go ahead and flame up the whole chat for me. If you would, I would really, really appreciate it. Then we'll go back to some questions. Can I get some flames, guys? Come on. There you go. Rosie's got it. All right, here. We're getting some. Got to get the whole chat full of flames. Nothing but flames. Let's get it going. Kathy Keats has got the right idea. Ella's got the right idea. Karen Tweed has got it going on. Aaron, there we go. Cassie has it. Brian G has it. Okay, there we go. We're almost got it. I think we did it. Yay. Thank you, guys. Thank you. Thank you. All right, cool. So I appreciate you doing that. It lets me know that you're there. Lets me know that you're excited. All right, so let's go back to some questions. I'm going to try to rewind back to where I left off best I can. And any ones I don't get to, I'll pick up later. All right, so Barry Homestead writes, oh, this is to somebody else. All right, so Lemon Peel Angelfish. Hey, how are you? Howdy, Dr. Boster. Question, is it true that steroids don't affect the outcome of a relapse, just speed up recovery? MS Trust UK website. So there's data that suggests that, but I think it's really old. Most people cite this ancient trial called the optic neuritis treatment trial. And there's other data that suggests that if you give steroids, the person's going to end up wherever they're going to end up, whether you give steroids or not. I said that in a very confusing way. Let me start over, okay? All right, starting over. There are papers that suggest that whether or not you take steroids, you're going to end up at the same place at a certain amount of time. And I call BS because I don't think that makes any sense. Moreover, what's happening during an attack is inflammation in your brain. So even if the functional outcome isn't changed with steroids, which I think it probably is, I think quelling the inflammation in your brain so we don't leave it there smoldering, I think is a really good idea. So I understand there's data that supports that, but that's not my clinical experience. And that is not my impression giving people treatment. I think very often we hasten the recovery of an attack. All right, Marilyn writes, what MS pill can be suggested after getting off Rebif? So there's a lot of pills. I think that we have to do a really good job, Marilyn, of understanding you and your goals and understanding your other comorbid risk factors so that we can really find the right pill for you. So, there's a bunch of MS pills out there, and I think that there's a very high likelihood that we could find one that's a good fit for you. Liam writes, have you known seizure meds can cause anxiety? I'm on Keppra, seizure-free since 2010. My neuro wants to try reducing, but I'm nervous because of driving. So that is a very, very intense, complex question. But Liam, I really can't speak to specifics of you. People impacted by MS are 6 times more likely to have seizures compared to the general population. And Keppra is a very commonly used medicine. It's a go-to medicine for most neurologists, myself included. Carla writes, I was diagnosed with hyperacusis, which is a doctor word for stuff's too loud, which causes fear and pain in the ear, probably from my MS. And that's true. It probably is from your MS. And if you're in town, Carla, come over and see me. One gone thus. Hi, doctor. There are no odd clonal bands found in my CSF, but there was an ANA present. However, I do not have lupus or any other rheumatologic conditions. Have you come across this before? Yes, I have, but that's not enough information for me to say anything really intelligent. And remember, guys, I can't diagnose or treat you on the interwebs. Please try to frame your questions as generalized questions so that everybody can learn. So Kelly Butler writes, do you know Dr. David Chisnick? That name doesn't ring a bell, but that doesn't mean it's not someone amazing, or that maybe if I saw his face that I would recognize him. Elizabeth writes, how important are MRIs when you're 30 plus years in and have secondary MS? If you have a relapsing form of MS, or if you have primary progressive MS, until the age of about 60, I like to get a brain MRI every year and a C-spine every couple of years. Now, if you're stable as Mabel and you're past the age of 60, I may back off. Now, why am I saying age? Because contrast enhancement and therefore inflammation is a function of age, right? So I care about that a little bit more than the duration of your disease. If you have had stable disease, you're over 60, you've had a MS for 30 years, I can understand maybe not doing it so frequently. I will point out that the people with MS can still have new lesions even 30 years into the disease. It doesn't happen very often, but it can happen. And if you're taking a medicine, I think it's reasonable every once in a while to check just to make sure that you're not seeing new spots. Otherwise, you're taking the medicine and you're taking the side effects of the medicine and paying for the medicine, except that would be evidence that's not working. So just my 2 cents. Ron Watson writes in, I've been told that disease-modifying therapies don't affect symptoms, but only slow progression. If DMTs suppress the immune system, meaning that the CNS isn't under attack, wouldn't that provide some kind of relief? That's a very good question, Ron, and you bring up like a very, very good point. So I have heard it described before that if you're on a potent MS DMT, that you can see an amelioration of symptoms, particularly like fatigue. And I think that's true for the reason that you suggested. It's been my observation or experience that I'll have a patient and we're struggling, we're on a medicine, it's not working. We switch to another medicine, and not only does it control their disease, but some of their symptoms melt. And they may say things like, wow, this is really great. I feel better. I feel like my old self. And it always strikes me that I think that was a good fit for that patient. And I just wish I could figure out ahead of time who's who, because that would be awesome. But we don't really know how to do that yet. Bottom line is, I think particularly some of the newer MS DMTs, I haven't really seen that with the first line shots, but with some of the monoclonals, I certainly have. That's a good question. All right, Myrna writes, hello, I'm taking Ocrevus and I want to do a hair transplant. Can I? Or will it affect the new hair transplant? Definitely an awesome question that you'll have to ask the hair transplant person and the Ocrevus person so that they can coordinate, because the hair transplant doctor is going to have a bunch of information about the time for healing and things of this ilk. And the Ocrevus doctor, your neurologist, can coordinate the timing of the Ocrevus with the timing of the hair transplant so that they don't interfere with one another. But there's some specifics that you're going to have to sort out. So Tucker writes, I have 20 years of chronic migraines, was diagnosed with MS about 6 months ago. They think my migraines were just a manifestation of the MS. Yeah. That's stinky. And it can be tricky. I definitely see a lot of migraines in my MS patients, as I mentioned earlier. I'm sorry that you went so long. It's unclear. It's very hard to sort out whether that was that whole time or not without looking at scans. I wish you the best of luck, and I'm glad there are treatments for migraines and MS. Jennifer writes, same with me, Tucker. Pia writes, curious. On my recent MRI to monitor my MS, it was discovered that I have a brain infection. How will the doctor determine if it is PML or from my MS med? Not enough information, although different infections look differently on the MRI. And so we might be able to sort out one from the other based on the way that it appears. Marilyn writes, what other meds can you suggest? Oh, we've already answered that. Gray Sky Lady, can you have both bladder issues concomitantly? Yes, excellent point, Gray Sky Lady. Thank you. So remember a little bit ago, I was talking about bladder, and I said you could have an itsy bitsy bladder that can't hold much urine, or the bladder neck is closed and then you have retention. Now, exactly, you can have both. Both is called dyssynergy. And it's when you have a little racquetball bladder that can't hold any much urine and the bottleneck is, or the bladder neck is closed tight. So you can have retention where you don't empty all the way and frequency, which is super frustrating. And oftentimes we can use more than one medicine to address that. So we may put someone on one medicine to help the bladder neck and then another medicine for the bladder itself. And that's because the neurotransmitters involved in the bladder neck are actually different than the ones involved with the bladder itself, or the different drugs work in those different spots. And that's super cool. So we can use those two drugs to take care of those two problems. Now, if you guys wouldn't mind, let's push the thumbs up above 100. There's 150 you online. I'm loving that. Thank you. If you're digging this, go ahead and give a thumbs up. You'll have to leave the chat, you click the thumbs up, and then jump back in. It's 74 right now, and I'm hopeful that we can get that up above 100. So that would be really, really cool if we could do that. See if we can get up there. There's 90. Thank you for that 101. Thanks, guys. That's really awesome. So Sherry writes, should I be concerned about a superficial numbing of the lips and tongue? I would be. I would definitely bring that up to your doctor. Jay writes, Dr. Boster, what is the determining factor that causes you to go from relapsing MS to secondary progressive? So in reality, it's a spectrum. It's not like, stage 1, stage 2. In reality, people are having progression from as early as you can measure if you use special measurements. And the way I tend to think about it is in the lifetime of a human with MS, relapsing MS, a relapsing form of multiple sclerosis, the beginning of the disease process is going to be much more characterized by discrete attacks with probably very little observable decline in between attacks. Maybe some, maybe not much. Most of the disability early on is because they don't fully recover from an attack. That same human in, dare we say, the second half of the disease, that part of the disease is going to be more characterized by progression. They can still have attacks, but they're more likely to have disability accrued because of progression of disability. And it's a spectrum. There are definitions that are used, and they're a little bit complex. So the MS-based definition is the one that I like, which talks about having not had an attack in a certain amount of time and having certain features on your exam. Your EDSS has to be a certain number. There has to be motor involvement. There's a lot of, but it's a lot of different points, and it's statistically generated, looking at groups of people and saying if we see these characteristics, they're likely to have secondary progressive MS. I'll be honest with you, I don't like the term at all. It's not a good term because it's stigmatizing and it doesn't really help us. The thing is, the MS medicines, particularly the newer medicines, they do more than just decrease attacks and decrease new spots. They slow disability progression. And so if you have a relapsing form of MS and you haven't had attacks recently, that's good. But I still want you on a medicine because that medicine is going to do more than just protect you against an attack, which is important. But it's also going to slow brain volume loss, which you want, and it's also going to slow disability progression. There's a lot of goofballs that want to take people off medicine, and I don't agree with that. So Redhead Shell writes, I've been suffering heart problems since since last year. Can it be due to my MS? So unfortunately, it may be true, and not related, but I don't see a lot of heart problems associated with MS, and I wish you the best, and I hope that you can get it taken care of. Alan writes in, can BTK inhibitors reduce antibody production, in particular reduce thyroid antibodies? I don't know the answer to that. I am currently studying several BTK molecules at the Boster Center. We're doing several clinical trials looking at these BTK inhibitors in relapsing MS and primary progressive MS, but I don't know the answer to that question. And so that's going to be my homework. Thank you for asking that. I have good news. I'm starting to feel a little sleepy. It is 12:18. I'm going to wrap it up here, guys. My name's Aaron Boster, and I want to thank you so much for jumping online with me so we could do an Ask Me Anything Q&A. Do me a favor, and before we wrap up, keep throwing the flames in there. Go ahead and flame it up again. I love going back and seeing all the flames. It lets me know that you like what we're doing. So do that before we jump offline. If you would, guys, go ahead and flame all that up for me. And then any question I didn't get to, I'm going to go back and look at it later. So let's round things out with some flames, guys. If you could do that for me, I would love it. Let's end the live stream with flames everywhere. There we go. Aaron West has got some flames going on. Jane has got some flames going on. Thank you, guys. Thank you. Let the flames come in. Go ahead and fill the whole thing up with flames, guys. Yeah, I love it. Thank you. So with the flames running in the background, my name's Aaron Boster, and as always, thank you for learning about MS with me. It's my goal that through this YouTube channel, I can help energize you, I can help educate, I can help empower. Thank you for supporting me. You do that by liking, by subscribing, by sharing, by leaving comments. And it does more than that. It really creates this amazing, global, growing online community. We have people that jump on and participate in this YouTube community from all over the world, people all over the world impacted by MS. And it really fills my heart. It's kind of fills a bucket, so to speak, seeing that happen. Really, really cool. Now, you got some flames going in the chat, and I want to thank you for that. Have a great night. I'm going to hit the hay. I have a big clinic tomorrow. God bless. Take care. And until the next time I see you, be awesome.